Myself, Dr. JIBRAN Ahmad presents to you Simply Pathology, and today we are back with a very important session. Today we are going to discuss about the cytology reporting protocols. Okay, so this is a very important topic. Why? Because they are constantly being asked in your final exams. Okay, so in your MD DNB exams, if you see at least 2 questions are coming from the cytology reporting protocols. Okay, most commonly they are asking you about the Bethesda Thyroid or the Bethesda cervix or the Milan system of reporting or the Paris system of reporting. So these are the most commonly asked cytology reporting protocols. Okay, so pay a lot of attention, because right now we have a very big update in the reporting of thyroid cytopathology, as well as we are having some updates in the Milan system of reporting of the salivary glands. Okay, so this is very important from the exam point of view. Okay, so what we are going to do, that I have made a particular lecture based on all the cytology reporting protocols that exist. Okay, so this particular series will be covered in 2 parts. Okay, there will be part 1 and there will be part 2. So what all is covered in the part 1 and 2, let us see. So we are going to discuss about the Bethesda Thyroid, Milan system for salivary gland, Bethesda cervix, Yokohama IAC reporting format of the breast cytology, Paris system for reporting of urinary cytology, especially the urothelial tumors, the Sydney system of reporting of lymph node cytopathology. This is a proposed system. Okay, it is not yet into the clinical practice, it is a proposed system. And the PLAB system, that is a new system for the pancreas. Okay, so we are going to discuss mainly the Bethesda Thyroid, Milan system of reporting for the salivary gland, and the Bethesda cervix in the part 1. Okay, and the remaining ones we are going to discuss in the part 2. So a major update has come in the Bethesda Thyroid, okay, in the 2022, as well as a major update, not a major update, a minor update is there in the Milan system for salivary gland, which has also come in the 22. Okay, so we are going to discuss in details about the same. About the Bethesda cervix, we are going to see the 2014 Bethesda only, which has come in 2014. Okay, so let us start today's topic of discussion without wasting any more time. So remember, whenever you are given a question, okay, on the Bethesda system or any cytopathology reporting system, so you should always start with a generalized approach. Okay, first few lines you should write that what is the importance of a standardized cytology reporting format. What is the importance of that? Okay, so for example, even if they are asking you Bethesda Thyroid or Milan or cervix or Yokohama, you should always start in this particular manner. So this portion is common across all the cytopathology diagnostic reporting system. Okay, so if you see the basic idea of any cytology protocol, it is to introduce standard diagnostic categories, each having an implied risk of malignancy that is used worldwide, and all these terminologies, they are reproducible across the globe. A common diagnostic category serves to remove any confusion with regards to the nature of the lesion. So for example, if we are having a single reporting system, so a doctor in India will call the same lesion as benign as a doctor in Europe or a pathologist in America. Okay, so if a standard terminology is there, if all people they are following a standard terminology or a standard reporting format or a standard diagnostic category format, then it is very easy for understanding the nature of the lesion, whether a lesion is benign or it is malignant. Okay, whether it is non-neoplastic, whether the sample is inadequate, whether there is ATYPIA of undetermined significance. Okay, so these terminologies becomes very clear. Okay, now such reporting protocols, they allow for a better communication between the clinician and the pathologist. For example, okay, so by the pathologist, for example, if we are reporting a particular specimen and we are just reporting, okay, giving a description, and then we are saying it can be this or it can be that. But for example, if I am writing a standard category that it is a benign lesion, or for example it's a ATYPIA, so the clinician, when they see the report, they will be able to understand exactly what is the next step that they have to follow. So it allows for a better communication between the treating clinician and the pathologist, as well as between institutions. For example, I have reported a particular slide. Now in my institute, they do not have the facilities for providing the treatment for that particular patient. So I will be referring that particular patient with that FNSC report to other institution. So when the other institutions see my report, they get a clear-cut idea, okay, what is it I am dealing with and why the patient was referred and what is it I have to do. So it is allowing, so any standard cytology reporting protocol is allowing for a better communication between the clinician and the pathologist, as well as between the institutions, leading to better patient care. Such reporting protocols also guide us about the ROM, that is the risk of malignancy, and what is the next line of action, whether I just should clinically correlate or I should do a radiological correlation, or the patient should be kept in a follow-up, or any surgical interference has to be done or no, or any further ancillary investigation has to be carried out. So for this, we are having this standardized protocol. So you can add these few lines across any of these reporting format. Okay. So without wasting any time, let us first start with the Bethesda Thyroid. That is the third edition, which is the latest edition of the Bethesda Thyroid reporting. So it is called as the Bethesda system for reporting thyroid cytopathology, TBS RTC. This is what it is called as. So very importantly, remember, the NCI sponsored the conference on thyroid FNSC in 2007 in Bethesda and recommended the use of the terminology for reporting of thyroid FNSC. In 2017, subsequently, the Bethesda terminology was further modified in the second edition. In 2023, actually in 2022 it came, and 2023 it was published. So in 2023, the most recent third edition was published, which simplifies the reporting structure by settling on just one name for each of the 6 categories and aligning the terminology with the most recent WHO classification of the thyroid tumor. So what is new in this particular edition? This is a very important exam viva question. So what is new in the third edition of the Bethesda? So there has been a unification of the diagnostic categories under a single name. So there is a unification of the diagnostic categories under a single name. So what is the difference? So what we want to say, so previously in the second edition we used to have non-diagnostic or unsatisfactory, but in the third edition we do not want any confusion and we are only sticking to one name for one category, that is non-diagnostic. Similarly, in the second edition we used to have ATYPIA of undetermined significance or follicular lesion of undetermined significance, that is the FLUS. So we used to have AUS and FLUS, but now we only have a single heading, that is ATYPIA of undetermined significance. Okay. Then we are having the follicular neoplasm or suspicious for follicular neoplasm. Now we are only having one heading, that is follicular neoplasm. Okay. So now what is the most important change is that there is a unification of the diagnostic categories under a single name. What is the second important change? Now the data informing the use of TBS RTC in the pediatric population is now included. So we are now having a separate reporting system for pediatric thyroid tumor, because now the data is available. Okay, so the data has become available over a period of time. So the risk of malignancy for pediatric thyroid tumor is available, and these risks are higher in children as compared to the adult population. Okay, so all the data with regards to the pediatric population is available. Now the ROM, that is the risk of malignancy, okay, has been further refined. Okay, the ROM has been further refined. More formalized subcategorization of ATYPIA of undetermined significance based on the ROM. Okay, now remember one thing, the AUS has been further subcategorized as AUS with nuclear ATYPIA and AUS others. Okay, then we are having the terminology. Okay, different terminologies which has been used has been harmonized with the latest WHO 2020 classification of the tumors of the thyroid. Okay, so we are in line with the 5th edition of the thyroid tumors. Okay, now very importantly in this particular session or in this particular video that I am teaching you, so over here we have basically introduced, or we have basically discussed the Bethesda system with from the exam point of view, okay, from whatever you can say in the exam, because in the exam you cannot write each and every point and the criteria and the diagnostic definitions for individual tumors, but you should give a fair bit of an idea that what are the changes and what are the basic diagnostic categories, what are the implied ROM, what are the definitions for the broad headings, and what is the management. This is what you are expected to write in the exam, okay, and basic introduction as I have already discussed, okay. So having said that, it is not that I am not going to discuss the detailed criteria. I am going to provide a separate PDF, okay, for the criteria, and those criteria are mainly important not for your residency, but rather it is important for the practicing histopathologist or for the practicing cytologist, okay. So in that case, those criteria become important. So I am going to just attach a particular PDF showing the individual criteria across all the types, whether it is be for thyroid, for Milan system, or that is the salivary gland, or for the cervix, or for the different systems. So right now we have to see that what are the important 6 diagnostic categories for the Bethesda thyroid. So first of all, we are having a non-diagnostic, benign, ATYPIA of undetermined significance, follicular neoplasm, suspicious for malignancy or malignancy. So you see there is only a single term that we are using. There is a unification of the diagnostic categories. So now we are going to discuss the individual categories or the individual broad headings. So we are going to see what is the definition of that, what are the entities which are included over there, what is the ROM, and what is the management for that particular diagnostic category. So number 1, non-diagnostic, the definition is the diagnostic line term for specimens that fail to meet the adequacy requirement. Now you must be thinking that what is the adequacy requirement? That requirement has been discussed in details in the individual topics that I have already taken in the website. So please visit the website or the app. Okay, over there you can see the adequacy requirement. Okay, so what are the entities which are included in this non-diagnostic category? Cyst fluid only, virtually those specimens which are acellular, or others, for example when there is obscuring amount of blood, clotting artifact, or there is a drying artifact. The risk of malignancy over here is 13%, the range is 5 to 20%, okay. Remember, in the latest edition of the Bethesda thyroid, the ROM has been revised and there is a great difference in the ROM with comparison with the previous edition, so please stay updated. What is the management for this particular diagnostic category? You should repeat the FNSC with the USG guidance. You should repeat the FNSC with the USG guidance. Okay. So this is very, very important. The next important is the benign category. Remember, the benign category, it is the most common FNA interpretation, accounting for 60 to 70% of all the cases. So what is the definition? So to report the benign cytopathology result, the diagnostic category terminology of benign is preferred. It is further subclassified into follicular nodular disease, thyroiditis, or other less common entities. Now remember, over here, whatever criteria has been laid down in under the benign headings, that is met, and that is why when all the criteria are met and you are very definite about the diagnosis as benign, then only you are using the benign heading. Now remember, nodular goiter, it is the most commonly sampled lesion by FNAC, and chronic lymphocytic or Hashimoto's thyroiditis, it is the most common form of thyroiditis which is encountered. So what are the entities which are under the benign heading? Consistent with follicular nodular disease like adenomatoid nodule or colloid nodule, consistent with chronic lymphocytic thyroiditis, that is Hashimoto's thyroiditis, or consistent with granulomatous subacute thyroiditis. What is the ROM? It is 4% and the range is 2 to 7%. What is the management? You have to go for clinical as well as sonographic follow-up in such cases, okay. Whereas if we had seen in the non-diagnostic category, we have to repeat the FNSC with USG guidance. Now, ATYPIA of undetermined significance. So previously along with this we had FLUS or follicular lesion of undetermined significance, but that terminology is no longer used. So what is the definition? Please pay a lot of attention. You have to write the exact definition. This terminology is reserved for specimens that contain one or more of a heterogeneous group of findings that raise the concern for the neoplasm or malignancy but are insufficient to be classified as a follicular neoplasm or suspicious for malignancy or malignant. So they are having one or more heterogeneous group of findings that is raising the concern for a neoplasm, but with definite confidence you cannot say that they are either a follicular neoplasm or there is a suspicion for malignancy or there is a malignant tumor. On the other hand, the findings are more marked than that can be ascribed confidently to the benign changes. So you can neither keep them under the benign nor you can give it under the follicular neoplasm or SFM or malignancy. So what are the entities? There are two entities. As I told you, the ATYPIA of undetermined significance, they are divided under AYUSH nuclear ATYPIA and AYUSH others. Okay. What is the ROM over here? It is 22%. The range is 13 to 30%. What is the management? You should repeat the FNSC or you should go for the molecular testing, or you can go for diagnostic lobectomy, or you can go for surveillance, clinical follow-up, or you can go up for the for the radiological follow-up as well. The next diagnostic category is the follicular neoplasm. The diagnostic category follicular neoplasm refers to moderate to markedly cellular aspirate that is comprised of follicular cells in which most are arranged in an altered architectural pattern characterized by microfollicle formation and or significant cell crowding, trabeculae or single cells. So this is very, very important. These definitions you have to write in the exam. So the entities which are included over here, remember, you have to just state as follicular neoplasm. Remember, if oncocytic changes are there, you have to label as Hurthle cell type. What is the ROM? It is 30%. The range is 23 to 34%. Now the management, what is the management that you are going to give? Okay, the management is either you go for the molecular testing. In addition to that, you can go for diagnostic lobectomy. The next important category is suspicious for malignancy. So what is the definition? The diagnostic term is used when some cytomorphological features, most often those of papillary thyroid carcinoma, raises a very strong suspicion of malignancy, but the findings are not sufficient for a conclusive diagnosis. The morphological changes are of such a degree that a malignancy is considered more likely than not. Okay, so this is very, very important. You should always remember the definition very clearly, and what is the meaning, that should be very clear in your answer. Then only the examiner is going to give you full marks. So what is the entities that are included over here? When it is suspicious for papillary thyroid carcinoma, suspicious for medullary thyroid carcinoma, suspicious for any metastatic carcinoma, suspicious for lymphoma or others. What is the ROM under this? 74%. The range is 67 to 83%. What is the management? You can go for molecular testing and you can go for lobectomy or near total thyroidectomy. Next, we are having malignant diagnostic category. So it is used when there are clear-cut features or unequivocal, means without any doubt you are sure that the cytomorphological features are consistent with a malignant neoplasm. The entities over here are papillary thyroid carcinoma, medullary thyroid carcinoma, high-grade follicular cell derived non-anaplastic thyroid carcinoma. This entity is also including your basically poorly differentiated thyroid carcinomas, undifferentiated anaplastic carcinomas, squamous cell carcinomas, carcinomas with mixed features, metastatic malignancies, NHL and others. Okay. What is the ROM? The ROM is 97%. The range is 97 to 100%. What is the management? Lobectomy or near total thyroidectomy. Now, we have discussed all the 6 important categories which are used in the latest edition of the Bethesda reporting of the thyroid cytopathology. Now, we will just end this system just by looking at the format. Now, remember, in the format of the report, first very clearly you should write the general diagnostic category, whether it is non-diagnostic, whether it is AUS, SFM, malignant or benign. You have to say. Then you should subcategorize with a particular description and you should give a specific diagnosis, whether you are saying it is as a Hashimoto's thyroiditis or you are saying it as a papillary thyroid carcinoma or follicular neoplasm, whatever you are saying you should specify. And then you should also give a note if it is required. For example, you think that a flow cytometry examination has to be done, or for example, you feel that a particular lesion is a NEET-PG or a follicular variant of papillary thyroid carcinoma. So in that case, you should give a particular note. Okay, so these 3 things should make up the format of the report. Although adequacy is important part in the evaluation of the thyroid, thyroid system of reporting, but remember in the format, According to the Bethesda Thyroid 2022 reporting system, they have, it is not mandatory for you to include the adequacy in every report. Okay. As I told you in the latest edition, the Bethesda for the pediatric patient is also introduced. Okay. So what are the same 6 diagnostic categories are there, only the ROM is changed and it is higher in children as compared to adults. So for example, for the non-diagnostic it is 14% with a range of 0 to 33%. You should either repeat with the USG guidance. Okay, for benign lesions 6%, 0 to 27 is the range, clinical and sonographic follow-up. For AYUSH 28% is the ROM, repeat FNSC or surgery. For follicular neoplasm it is 50% surgery. For SFM, suspicious for malignancy, 81% surgery. For malignant lesions it is 98% risk of ROM and the definitive management is surgery. Okay, so this is the Bethesda for the pediatric patients. Okay, so having completed the discussion on the latest Bethesda 3rd edition of the thyroid, now we are going to discuss about the latest Milan system, that is the 2nd edition of the Milan system, which was published in the 2023. So the Milan system is used for reporting the salivary gland cytopathology using standard terminologies, thus fostering effective communication between